Just to remind you that we've got on the panel Yvonne Strachan at the far end, who's head of the Equality Unit, Professor Alan White, who you heard talking very eloquently about gender and cancer. We then have Martin, who you've heard from the Equality and Human Rights Commission. And at this end of the table, we've got Kath Denham, who's the Director of the Equalities and Planning Directorate at NHS Health Scotland. So, I wonder whether, does anybody particularly want to kick us off with any questions from the floor, or can I take some questions that were submitted earlier? Let me, in no particular order. There's a question here for the panel. It's in two parts, but how will LGB issues be considered, especially in regard to same-sex partnerships and or relationships in this? And let me cover the second part of this question as well. Most issues are based on a binary, i.e. woman-man system, and references are aimed at this divide. Transgender people transcend both sexes but appear to be considered only as male or female. What special arrangements are to be incorporated in formulating strategy? So, two questions. LGB issues, how do they play in? And secondly, specifically around transgender people, you know, any special arrangements there? Now, I wonder who might want to pick up responding to that.
I'm happy to have
say
one thing first off without answering everything. In dealing with LGB first, I think this really refers to the point I was making earlier about diversity and a recognition that there will be particular needs for both men and women, depending on, in this case, their sexual orientation, and how, therefore, the health service and how we respond as organisations to that. There has been, over the recent period, and I say recent in qualitative terms, quite a lot of advance made in recognising the needs of LGB communities, about being more open and responsive to how that needs to be dealt with, but acknowledging that there are some key issues about how we monitor, for example, which is not a straightforward exercise, how we respond to dealing with the issues that are confronted by those communities. I think the advance or the opportunity that's now being created by the legislative framework, which says for the first time that there will be an ability for us as a public sector to formally address these questions rather than doing it incidentally, as many of us have done. And that's a really positive advantage. So I think we're more likely to see change in the future than perhaps more quickly than we might have done now. In relation to transgender, this is a relatively new area for most people to address. It's still being worked out precisely how best we should deal with that, which is why organisations like Transgender Alliance and the work that's been done through the Alliance and others working with public sector bodies to help understand and improve the understanding around transgender issues, really, really important. I don't think we want to underestimate that we still have a lot of work to do in this regard, whether it's in the Scottish Government side, thinking about how we frame policies, but also what we need to do in practice. So I think really it's just a question at the moment of being at the early stages of that, but acknowledging it. And if we can acknowledge it, then we're one step towards being able to be open and receptive to what needs to be done.
On an individual level, I was really pleased to see in your presentation, I think, Yvonne, specific reference there to the quality strategy and what that might mean for individuals in terms of how they receive health services. And presumably, some of these policies all point in the same direction. Yeah.
Well, I think the general intention is that policies across the piece, whether it's on patient-centred services, which recognise the needs of the patient and not, so that services are responsive, patients' rights in that regard, then should be infused with an understanding around the equalities agenda, which is why Equally Well and the diversity dimensions and all the other things which have been done are about helping us understand. And I think somebody mentioned it, and I apologise, I can't remember who it was, but if we should capture this information that we have available, whether it's what Alan was talking about in relation to men's health or it's what others were talking about, and if we can use the information we have to help us evidence then what needs to change in policy, that's the essential element of the public sector duties.
Yeah, thank you. Does anybody else particularly want to address any of these questions raised in this LGB and transgender?
It's just a general point. I think it's also about making sure you hear the voice, because people can assume, and when you assume, if you remember, you make an ass out of you and me. And I think that certainly all the work I've done with gay men, and they say that you only ever hear about the sexual health stuff, and you forget the fact that when you're talking about weight loss, all they see when they see the marketing around weight loss is for either for women or for heterosexual men, and that they don't feel as though the message is getting to them. They don't think they're speaking at them or with them, and so therefore by being able to see it and experience it and to hear the voice and to see it from the perspective, then I think we can start to move on.
Is the different, I mean, it's quite a lot to ask people, you know, who've worked in a certain way for a very long time, perhaps. You know, what about education, ongoing education? Are there real challenges in that for health professionals, for people working to deliver these services? You know, listening, acting upon. Sorry to come back in again, but absolutely. I mean, I've been and spoken to medical students, and I've been given half an hour. They had 1 hour on gender in their 5-year course. There was half an hour for women's health and half an hour for men's health. And What else do they do then?
And you think, and it's a mockery. I've actually told them I'm not doing it because it's a mockery of something that's so important. And when their communication skills is only just becoming part of the curriculum in many medical schools. I know that some are fantastic and have been forward-thinking, etc., etc. But there's an awful lot that haven't, and so therefore we still have a big battle in getting appreciation of the breadth of people's lives, and it's not just the biomedical entity.
And moving this away from lip service to real action. Yeah. Kath, have you got Scottish perspective on that one?
Not particularly a Scottish perspective, but I think, I mean, as I said this morning, I think that to me is still the fundamental core issue around the training, education of health professionals, how they address these issues. But you can start there to some extent, but I think you also have to go one step further back, which again, where we started this morning, it is back to education more generally and the broad societal pressures, assumptions, etc. They're built into even when people come to our medical schools or our nursing colleges or wherever it might be. Already, and all of us have huge inbuilt assumptions in all of this, and it's.
What about recruitment then? I mean, are we looking to recruit sensitively enough from people in these groups? I mean, is there more we could be doing there?
There are signs that that's starting to happen. Certainly, I've seen some of that through some. My experience and background is mostly in medical education, but seeing some of that building into selection in medical schools, and I think we could see a lot more of that.